Neurology Quiz number 131. Describe the etiology, clinical features, and management of the following rare focal neuropathies: Cheiralgia paresthetica, Gonalgia paresthetica, and Notalgia paresthetica. Cheiralgia paresthetica or Wartenberg syndrome. Cheiralgia paresthetica is also known as Wartenberg syndrome or superficial radial sensory neuropathy. It is a pure sensory neuropathy caused by compression or irritation of the superficial sensory branch of the radial nerve. It causes pain, numbness, tingling, and dysesthesia over the dorsolateral aspect of the hand without motor weakness. Anatomy: the superficial radial nerve is the terminal sensory branch of the radial nerve. It passes between the brachioradialis and extensor carpi radialis longus tendons. It emerges approximately 8 to 10 centimeters proximal to the radial styloid. Here it becomes superficial and is vulnerable to trauma. The nerve supplies sensation to the dorsal thumb, dorsal index finger, radial half of middle finger, first dorsal web space, and dorsolateral hand. Sensation over the fingertips is preserved because this is supplied by the median nerve. Causes: external compression. This is most common. Examples include tight wristwatches or watch neuropathy, handcuffs or handcuff neuropathy, bracelets, tight casts and splints, and tight gloves. Number 2, repetitive forearm motions, especially forceful pronation, supination, and repetitive wrist deviation. This is seen in mechanics, electricians, gardeners, construction workers, tennis players, or golfers. Number 3, trauma, direct blow to the radial wrist, distal forearm, lacerations and fractures. Iatrogenic injury. It is common after IV cannulation over radial wrist, radial artery catheterization, wrist arthroscopy, and thumb surgery. Local masses such as compression by ganglion cyst, lipoma, etc. Systemic predisposition. Compression neuropathies occur more commonly in patients with diabetes, hypothyroidism, and rheumatoid arthritis. Clinical features: patients usually complain of pain, which is burning, aching, or shock-like, located over the sensory distribution of the nerve. Paresthesias such as tingling, pins, and needles. Symptoms worsen with wrist flexion, ulnar deviation, and forearm pronation, as well as with gripping. On examination, there is reduced sensation over dorsal thumb, first web space, and radial dorsum of hand. Tunnel sign: tapping over the superficial radial nerve 8 to 10 centimeters proximal to the radial styloid reproduces paresthesias. Electrodiagnostic findings: there may be decreased amplitude or absence of the superficial radial snap. Ultrasound: high-resolution ultrasound may show findings secondary to compression and associated abnormalities such as a ganglion cyst. Treatment: conservative. This is first line, in most cases resolved this way. Remove the compressive trigger, such as loosen or stop wearing tight watches and bracelets. Rest and activity modification. Avoid repetitive wrist flexion and extension or forceful gripping. Wrist splinting in a neutral position to reduce nerve irritation. NSAIDs for pain and inflammation. Physical therapy or nerve gliding exercises once the acute irritation settles. If conservative measures don't help after several weeks to months, can proceed with corticosteroid injections near the nerve to reduce inflammation and neuropathic medications like gabapentin. Surgical treatment. This is rare and only used for refractory cases. It consists of surgical decompression or neurolysis of the superficial radial nerve if symptoms persist despite conservative management and affect function. Gonalgia paresthetica. This is an uncommon focal sensory neuropathy involving the sensory nerve supplying the medial knee, most commonly the infrapatellar branch of the saphenous nerve. Anatomy: the saphenous nerve is the terminal sensory branch of the femoral nerve derived from L3-L4. It supplies sensation to the medial knee, anteromedial leg, and medial ankle and foot. The infrapatellar branch leaves the saphenous nerve several centimeters above the knee and crosses superficially over the medial aspect of the joint to supply the anteromedial knee, the infrapatellar skin, and the medial patellar region, as is shown in the figures. The branch is particularly vulnerable because it traverses fascial planes, passes near tendons, is superficial, and is exposed during many knee procedures. Etiology number 1, compression. The infrapatellar branch may be compressed by fascial bands, scar tissue, tight clothing or braces, by chronic kneeling. Entrapment usually occurs where the nerve exits the sartorial fascia. Number 2, trauma. Direct injury includes falls and sports injuries. 3, iatrogenic injury is one of the commonest causes and occurs following total knee arthroplasty, knee arthroscopy, ACL reconstruction, meniscal surgery, and vein harvesting for coronary artery bypass surgery. Number 4, degenerative knee disease. Patients with osteoarthritis and chronic synovitis may develop secondary irritation of the nerve. Number 5, diabetes. Diabetic patients are most susceptible to focal neuropathies. 6, less common causes are ganglion cyst lipoma or Baker cyst. Clinical features. Symptoms are mostly confined to medial knee, inferior patella, and proximal medial tibia. The area is only several centimeters in diameter. Symptoms include neuropathic itch, which is often the dominant symptom. It can be persistent and difficult to relieve by scratching and may worsen at night. In addition, there can be burning pain, tingling, and numbness in the area of distribution of the nerve. Intermittent sharp pain can occur, which can be triggered by knee flexion, kneeling, by climbing stairs, and prolonged walking. There can be allodynia, and pain is produced by clothing, by bed sheets, by touching the skin, and by kneeling. On examination, there may be reduced sensation and allodynia over the affected area. A Tinel sign may be elicited over the medial knee where the nerve emerges from beneath the sartorius. Investigation. Diagnosis primarily clinical, and EMG and nerve conduction studies are not helpful. Ultrasound may show findings secondary to compression. Nerve block of the infrapatellar branch with relief of symptoms supports diagnosis. Treatment consists of number 1, activity modification. Avoid prolonged kneeling, tight braces, compression garments. Number 2, topical therapy, which is helpful for mild symptoms, and options include topical lidocaine 5%, capsaicin cream, topical NSAIDs if there is concurrent arthritis. Number 3, oral medications. These are used for persistent neuropathic symptoms, and options include gabapentin, pregabalin, duloxetine. Number 4, local injections, often highly effective. Injection consists of local anesthetic and a corticosteroid. Ultrasound guidance improves accuracy. For refractory cases, other measures include pulse radiofrequency, cryoablation, and peripheral nerve stimulation. And finally, surgical treatment, which is reserved for persistent symptoms. Despite the above measures, procedures include neurolysis, decompression, and neuroma excision, etc. Notalgia paresthetica. This is a chronic sensory neuropathic syndrome characterized by localized itching, usually over the upper back, with or without pain, burning, tingling, or numbness. It is a neuropathic itch syndrome rather than a primary skin disease. Skin changes, when present, are usually secondary to chronic scratching. Etiology. The exact cause remains unclear, but current evidence suggests that notalgia paresthetica results from entrapment or dysfunction of the posterior primary rami of the thoracic spinal nerves, most commonly from T2 to T6. Number 1, peripheral nerve entrapment, which is the most widely accepted theory. The dorsal cutaneous branches of the thoracic spinal nerves emerge through the multifidus and trapezius muscles and make a nearly right-angle turn before reaching the skin. They are susceptible to chronic mechanical irritation, muscle spasm, fascial compression, and fibrous entrapment. Repeated irritation results in neuropathic symptoms. Degenerative spine disease. Many patients have cervical and thoracic spondylosis, and MRI often demonstrates degenerative changes at levels corresponding to the symptoms. However, similar abnormalities are common in asymptomatic adults, and therefore degenerative disease is considered a contributing factor rather than the sole cause. Number 3, muscle dysfunction. Many patients have tight paraspinal muscles, trapezius spasm, rhomboid dysfunction, and poor posture, and these abnormalities may compress the cutaneous branches. Other associations have included diabetes mellitus, herpes zoster, trauma, spinal surgery, high BMI, and repetitive upper body activity. Clinical features. Patients are usually middle-aged or older and female. The classic location for symptoms is the medial border of one's scapula, usually between T2 and T6 dermatomes, most commonly right-sided, occasionally may be bilateral. The primary symptom is chronic localized itch. This is severe, intermittent, or constant, deep rather than superficial, and often difficult to relieve. Typically, patients scratch with door frames, corners of furniture, and back scratches. Patients may also report burning, tingling, numbness, or deep aching. Examination is usually normal. Occasionally mild hypoesthesia, hyperesthesia, or allodynia may be seen in the affected area. Skin findings. The skin is usually normal. Later there may be hyperpigmentation, lichenification, and excoriation. These changes result from repeated scratching rather than being the primary disorder. An example of hyperpigmentation is shown in the figure. Investigations. Diagnosis usually primarily clinical based on chronic localized unilateral itch in a medial scapular location with minimal primary skin abnormality and failure of dermatologic therapies. MRI of the cervical or thoracic spine may be considered if symptoms like neck or back pain suggest radiculopathy. Treatment. Number 1, physical therapy. Goals include improve posture, stretch thoracic, paraspinal, and pectoral muscles, strengthen scapular stabilizers, and reduce muscle spasm. Patients with poor posture often improve substantially. Number 2, topical medications like capsaicin. This is the best studied topical therapy. It can significantly reduce itch. However, disadvantages are it can itself cause a burning sensation. It requires frequent application and symptoms often recur after discontinuation. Another alternative is lidocaine. A topical lidocaine 5% patch or cream provides temporary relief. Pramoxine, a topical anesthetic, may reduce itch for several hours. Menthol produces a cooling sensation but is useful only for mild symptoms. Number 3 includes oral medications. Medications used for neuropathic pain are often effective. Gabapentin reduces itch intensity and improves sleep. Alternatives include pregabalin, duloxetine, and tricyclic antidepressants. Number 4, botulinum toxin. Initial reports suggested benefit. However, subsequent trials have shown inconsistent or negative results. It is not routinely recommended but may be considered in refractory cases. Number 5, injections. Trigger point injections with lidocaine and a corticosteroid or paravertebral nerve blocks. These are occasionally used in severe refractory disease. Benefit, however, is usually temporary. Transcutaneous electrical nerve stimulation. Some patients experience reduced itch. It is often combined with physical therapy.